Please start.
Yeah. So good morning, everyone. This is Dr. Sonal Mehta, INTAS. Welcome you all. INTAS being a strong presence in fertility business and being a knowledge partner to engage you all during this COVID-19 outbreak. We at INTAS, the team headed by Mr. Satpathy, has organized this live webinar with esteemed faculty, Dr. Christos Venitis from Australia. I welcome you all to this webinar given by Dr. Christos Venitis on ovarian stimulation to improve live birth. Dr. Christopher Venitis is a consultant gynecologist and fertility specialist, director, clinical research, IVF Australia, Sydney. He has an author of more than 85 publications in international scientific journals and of several book chapters, and he has been invited speaker in numerous international scientific meetings. He has been editorial member of Board of Human Reproduction since 2018 to 2008, and he is section editor for the RBM Online. His research interest includes ovarian stimulation, endometrial receptivity, and reproductive epidemiology. With this, I welcome Dr. Christos to begin the seminar. Welcome you, sir.
Thank you, Dr. Sonal, for the introduction. And of course, I would like to thank everyone for their presence. I really aspire for this webinar to be a very educational one and informative one. And I would like to thank INTAS for the very kind invitation. It's great to be part of this educational initiative. Obviously, these are trying times for everyone amidst the COVID-19. So it's really admirable that, during these times, we find other ways to keep educating ourselves regarding fertility and make sure we add some level of normalcy about our everyday lives. So I was asked very, very kindly to give a presentation on how we can potentially optimize live birth rates by how we can optimize ovarian stimulation in order to maximize live birth rates. And so this is what I'm planning to do in the next 40 to 45 minutes, present my view based on the evidence that we do have available. I'm not sure, can we please confirm that everyone can see that my slides can be seen?
Yeah, we can see it
now. Excellent. Okay. So let me start first by obviously disclosing the fact that I have in the past received support from many different companies, honoraria and unrestricted research granting. But at the same time, what I feel I will do in the next few slides is present the available evidence for educational purposes without any particular bias. So I would like to start by just stating the obvious. We many times as physicians, as clinicians, trying to understand what is IVF about, what is the aim of IVF, and whenever we're actually examining any medical treatment, I think the best approach we can have is try to examine whether our treatment is useful on the basis of 4 different pillars. One is efficacy, is what I'm doing actually improving, useful in what I'm trying to achieve. The second is safety. We should never forget about safety because something might be very efficacious, but if it's has a very aggressive profile of adverse reactions, then that might not be an acceptable treatment for patients. The other thing would be, what is its cost? Obviously, cost is a very important factor in many, many countries, so we need to take that into account. And last, but certainly not least, what is the patient acceptability? Do patients actually accept the proposed treatment? And if so, do they have any specific preference? So the aim of IVF is probably, to have a healthy baby. That's what all our couples want. Then the next question would be, why do we do ovarian stimulation? What is the aim? And I won't go through the details of why potentially ovarian stimulation is useful compared to just natural cycles. These all are questions that have been addressed and have been answered by in the early 80s. But if we were to agree on the answer to this question, what is the aim of ovarian stimulation? I think that most of us would say that it is just to obtain a good a good number of good quality oocytes. But then the question that comes immediately after that is how many oocytes? Excuse me, someone has not muted the microphone. Can I please ask? Thank you. So the next question would be, how many oocytes? What is the appropriate response for patients? And that's something that many doctors have been troubled with for quite some time. Is there a magic number? Is there a number that apparently is the sweet spot between efficacy and safety? And this is what we'll be largely examining, in this first part of the presentation. So I can start by saying, and I think we can all agree to that what we don't want to have is 0 eggs. And this is, again, many of the images that you'll see in this presentation have been taken by, like from the internet, from blog posts of patients that had either a very good or a very bad experience. So in this picture, you can see how one patient wanted to express her devastation when, despite all the injections that she was having, she ended up having 0 eggs. But on the contrary, like at the other end of the spectrum, we definitely don't want to overstimulate the patient or take them to, realms of numbers that potentially are, very, very dangerous for them. This again comes from a YouTube video where this particular patient was outlining how she felt she came very close to death because her doctor stimulated her so hard that she had an egg pickup with 91 eggs. I'm not sure whether anyone here would consider that an appropriate or an acceptable number. I certainly think that this is clearly an indication that things got out of hand. So to answer the question of whether there is a magic number, many scientists and many clinical researchers and epidemiologists have tried to accumulate data and see whether indeed there is an association between the number of oocytes retrieved and the number of the chances of a live birth. This is a very prominent paper in the literature coming from Sankara and from the UK, where essentially by analyzing the HFEA data and more than 400,000 cycles, she saw that the more oocytes you would get, you would have a higher chance of a live birth. And that seemed to plateau around 15 to 20 eggs. And then after 20 eggs, someone could start observing a slight decline, which after 30 eggs became even more prominent. So that led these researchers to say that probably the optimal number in terms of oocytes retrieved should be around 15 to 20. Obviously, if you can get to that number, let's not forget that. And the same researchers postulated that the potential reason for the observed drop after 20 eggs might be the poor oocyte or embryo quality. It might be the reduced endometrial receptivity or other factors that might be unknown. Okay, and many of you would say this is just one study. Do we have any other evidence? So the next study that comes now from the USA using the SART data between 2008 and 2010, so fairly more recent data. Again, a very a study of substantial size between like around 256,000 cycles, and you can see more or less the same trend. The more oocytes you get, the higher the pregnancy rates. This time, the maximum pregnancy rates seem to be achieved around 21 to 25 eggs, and then again we start seeing that drop. And for that reason, these authors in the United States of America said that for them, and based on their own data, apparently 21 to 25 eggs seems to be the magic number or a range of magic numbers. And again, more or less, they postulated the same factors as potentially responsible for the observed drop after 25 eggs. One thing, obviously, we should not ignore from this chart is the fact that these these researchers also managed to plot the risk of OHSS. And you can see that essentially it follows an exponential growth, which means that it starts from being, 1 in 1,000, and by when we reach to more than 25 eggs, it has reached to 6.3%. So that is something we need to take into account when we're thinking about how we should stimulate our patients. In a more recent attempt, we utilized the ANSWER database, which is the Australian database of ART, and it includes all cycles, both from Australia and New Zealand, for many, many years, from 2003 onwards. We chose to use the data from 2009 to 2015 because we felt we wanted to make them as relevant to today's practice as possible. And on the day that we sought ethics approval, these were the data that we had available. Again, this essentially made a data set of about 256,000 cycles, which is a substantial data set and fairly similar to the SART data. And this is what we observed in terms of fresh embryo transfers. One thing we did do differently is we analyzed the association between the number of oocytes, which you can see here on the x-axis, to the predicted live birth rate based on the data, which you can see here on the y-axis. But what we did is we wanted to see what would be the effect of age, because we do think, and we have shown, that essentially age can be an important effect modifier. So continuing, if you see now here the trend, you can see that for very young women between 18 to 29, the maximum live birth is already attained by 9 oocytes. And then probably until roughly 15, it seems to be high. And then there is a decline. And this is just fresh embryo transfers. I need to emphasize that. For 30 to 34 and 35 to 39, you can see again that we have a very quick rise, as you would expect. And it appears that the maximum live birth rates per fresh embryo transfer seem to be attained around 12 to 15 oocytes, and then we see a drop. For women that are 40 to 44, probably the maximum live birth rates are attained around 15 oocytes, and they seem to remain unchanged until 20 oocytes, and then we see a slight drop. Lastly, for women 45 years and older, this really extreme group of advanced ovarian age, we can see that essentially their chances are extremely small, and most of them have less than 10 eggs. And if we want to be pragmatic, there's not a huge difference in terms of pregnancy rate with advancing number of oocytes, based on the limited numbers that we do have. And these chances are, if we are talking realistically, quite small. But this is obviously something we know. But what about cumulative live birth rates? Because another very important thing we need always to be mindful of is that both the Sankara paper and the Stewart paper from the United States both look at the fresh embryo transfer. I think nowadays more and more of us are actually becoming aware that many patients would like to see an egg collection, not just in terms of what is the chance of me getting pregnant with the first or the fresh embryo transfer. What is the chance of me having a baby from that egg collection, whether that baby comes from the first embryo transfer or from subsequent frozen embryo transfers? And we do feel that was a very, very relevant clinical question. So with my colleagues, we published, again, using the ANSWER data, we published this study in Human Reproduction just in the beginning of last year. And again, we stratified the data according to age, because we felt that's a very important effect modifier. And again, if you look at the curves, you'll see that that is indeed true. And in these cases, when it comes to cumulative live birth rates, and I need to make sure the distinction is clear between this slide and the previous slide, which is the data affecting only fresh embryo transfers. Essentially, you can see that, and probably this is much better. It's essentially the same slide, but we've substituted the rhabdograms with this type of graphical representation. You can see that for women 18 to 29 and potentially 30 to 34 and 35 to 39, we have an increase And this increase almost keeps on going indefinitely. Someone could say that the younger women might reach a plateau after 25 eggs or around 30 eggs. Whereas for women between 35 and 39, that plateau never seems to be reached. Essentially, the more eggs you have, the higher cumulative chance of a pregnancy, of a live birth you'll have, meaning the higher chance that from that single egg collection, you have at least one live birth. Finally, for women that are 45 years or older, again, we weren't able to observe a significant difference. And yet, I don't think it's very clinically relevant to discuss that specific part of that study. So just by looking at the previous examples, we saw that for fresh embryo transfer, we do have a range. And that range, if I had to pick a sweet spot, I would say for most women is around 15 eggs. Obviously, there are slight differences between the different studies that have been published, but I think almost all of them do include 15 as part of their optimal range. And then we do see a drop, and that drop might be potentially due to the fact that we have eggs of inferior quality, or what might probably be more the case is that we do have a compromised endometrial receptivity. And these are things I will be presenting in the next few slides. So looking again back to what this slide showed us is that if you have a poor ovarian response, that is not a great thing, because we all know how this can impact our chance of pregnancy dramatically. But at the same time, when you have way too many follicles and too many eggs, then we do know that you have an exponential growth in OHSS. And that's something that ourselves and others have shown many, many times in the past. And this is again coming from the ANSWER data, where this is the OHSS risk. This paper is currently under review, and hopefully very, very soon it will be out. And you can see here that again, the same exponential growth in terms of severe OHSS risk is observed with higher number of eggs. And what is interesting, and the reason why I wanted this slide to be here, is you will observe that, and that's something that has not been discussed sufficiently in the past, that for years we felt that the only thing that's important is the estrogen and the oocytes. This is no longer the case. We know now that even age is a very important factor. And the reason for that is younger women seem to be far more prone to have severe OHSS compared to older women with the same number of eggs or follicles retrieved. And I think that's something important that needs to be always taken into account. So why are we so obsessed with OHSS? Well, because we always have to have in mind, this is an elective procedure. So losing patients due to OHSS, or ending up with patients in an ICU bed or in our HDU bed due to something we did or something we did not do, is something that none of us wants to see. So I always feel, and I encourage you all to go on this YouTube channel and watch this woman's story about how something very hopeful, like trying to have a baby, ended up being a nightmare for her. I think these are very didactic examples, and whenever we are making decisions about our patients' management, we should always make sure we keep these things into mind. So now we're coming to something that has probably been occupying the realm of academic and scientific discussion in ovarian stimulation for quite some time, and that is, if we get more eggs, does this mean we're getting eggs of inferior quality, or does this mean the embryos will end up getting are worse? So for years, I've been listening to this argument, particularly from some colleagues of mine, and it was in most cases based on really sketchy evidence, if I'm allowed to say. And that's why I wanted to explore and see how things would actually be if we took this example to the extreme. And what is this extreme? If we wanted to see, and because that's the most relevant thing, what is happening with the number of embryos we have, and not just a number, but what is happening with the number of genetically normal embryos we're having, which is, I think most of us, we agree, one of the most important things and outcomes in modern IVF. And in order to see that, we did a study with my colleagues at IVF Australia, where we took more than 700 cycles of women that had been had undergone a cycle of pre-implantation genetic testing for aneuploidy, and we wanted to see whether the number of euploid embryos was actually associated with the number of oocytes that someone retrieved. And again, this is a paper which has been published in Tumor Reproduction, and I encourage you to go and have a look. I think it, it puts a very interesting perspective. Again, because we do know now that age is an important moderating factor, we did make sure we looked at the association in different age groups. And here you can see that what that study showed is that indeed, the more oocytes you have, the more euploid embryos you'll end up with. And this is something very important because we do know that these are the embryos that have a chance of giving us a live birth. And this is why we're doing ovarian stimulation, to make sure that we end up with lots of good quality embryos, and being genetically normal is obviously the best criterion we can have. Again, if you observe the graph, you'll see that younger women, the more oocytes they had, the greater the benefit would be in terms of the number of euploid embryos. Whereas for older women, there was still a benefit. For example, this is a 40-year-old woman. You can see that if she had 5 eggs, on average, she would end up with 0.7, 0.8 genetically normal embryos, and these are means, so you have to take that into account. And if she had 30 eggs, she would have 1.9 genetically normal embryos. So she would end up with more genetically more normal embryos, although the actual number of genetically normal embryos would decrease. And this is, for example, expressed in this example. So when you're 34, to obtain either 1 or 2 euploid embryos, you need 5 or 14 oocytes respectively. When you're 38, just 4 years later, to obtain 1 and 2 genetically normal embryos, you need 10, double, and 24 oocytes respectively. And that actually puts things into perspective. There is benefit for everyone, but obviously the benefit in terms of the absolute benefit is higher, is larger in younger women. The same data and almost, the same data were actually produced by a smaller study, but yet a very interesting study by Elena Labart and colleagues, where she looked at the same association in 51 egg donors. So these are not infertile patients, these are good quality donors. But again, she observed the same association. The more oocytes you have, the higher the chance and the higher the number that you'll end up with genetically normal embryos. And this is very, very important. So let's continue. What about implantation? We always know that having a genetically normal embryo is great, but to have a live birth, which is what we're talking about here, you need to have a good endometrium. And obviously, most of you have seen, this is one of our publications back from 2013, where essentially we showed that when you have high progesterone, that progesterone can actually detrimentally affect your pregnancy rates in the first transfer, in the first cycle. And although many of us use that 1.5 as a nanograms per ml as the cutoff to classify or to characterize a cycle as having a high progesterone or not, that systematic review and meta-analysis identified that a negative effect can be present with cutoffs as low as 0.8. Obviously, when you have 60,000 cycles analyzed, these numbers can all of a sudden be able to give you statistical significance, whereas in smaller studies, obviously that is not the case. So have that in mind. You don't have to have 1.5 or 1.6 nanograms per ml in order to observe these effects. That effect can actually creep in at a significantly earlier stage. And why is this relevant to the discussion we're having today? Because we do know that the more oocytes retrieved, the higher the progesterone, because the progesterone is mainly attributed to the cumulative amount of progesterone secreted by all the small follicles that you have created, with your ovarian stimulation. And this is a chart just for, that it's not published yet, where essentially it shows that the more oocytes you have, the higher the chance that you'll end up with elevated progesterone of more than 1.5 nanograms per ml, which is exactly what we have been describing and what we've been discussing so far. So if I was now having all this knowledge and incorporated in my original statement, What is the aim of ovarian stimulation? The aim of ovarian stimulation is not just to get a good number of good quality eggs, is to maximize the oocyte yield, but without significantly compromising endometrial receptivity or increasing the chance of HSS. And I think this is how we should be looking at things, because we always should be evaluating our management decisions on the basis of the 4 pillars of clinical management: efficacy, safety, cost, and patient acceptability. So that means that we need to somehow individualize ART, and how you can do that. First of all, you can identify the extremes of ovarian stimulation, the poor responders and the hyper responders. Then you can titrate the FSH starting dose, and in that way, hopefully you'll have the optimal oocyte yield. Do we have predictors for poor ovarian response or hyper response? Well, yes, we do have some biomarkers. Obviously, a good biomarker has to be accurate, has to be reproducible, has to be of good discriminating capacity, good prognostic classification, non-invasive, as ideally would be non-invasive, and obviously an important factor is always cost. So many have been tried, but currently we do know that the ones that seem to have the most promise is the female age. That's always an important factor, but also the AMH and the AFC. So what is the evidence regarding the AMH of the AFC? I won't actually go into further detail, into much detail. Simone Breuer has done an excellent PhD on this. And essentially in both cases, he says that both AFC and AMH have a good capacity of predicting hyper response, and that capacity seems to be equal. And the same applies for predictive reticulic response. Both of them can predict poor response. They have clinical value, and they have to be more or less of similar capacity. So you can use AMH or AFC depending on what you want to do. It depends on, for example, particularly for the AFC, you need to make sure that the one who's looking at the AFC is someone who can really know to measure AFCs, whereas with the AMH and with the latest assays, things probably are slightly more standardized. So we do have the markers, and we do know, what type of patients we have. The next big clinical decision would be what FSH to use, because FSH from FSH or gonadotrophin from gonadotrophin might differ. We do all know the history of gonadotrophins, how we started initially just by menotropins or menopausal gonadotrophins, and then we had highly purified, again, urinary gonadotrophins, and we ended up now having recombinant gonadotrophins, folitropin alpha, folitropin beta. These are the most known, and recently we have corfolitropin, folitropin delta, gamma, and so on and so on. So why did we have to go recombinant? Well, because first of all, the purity levels are entirely different, and we can have all of a sudden an endless and reliable source of gonadotrophins, and that's a huge importance. We can have high batch-to-batch consistency, and that's also very important when you're managing patients. These allow for subcutaneous administration, which is far more, acceptable from patients. And of course, there are no concerns regarding potential disease transmission compared with any urinary-derived products. So many gonadotrophins are available today. Some of those might not be available to India or to other countries. These are the urinary products. These are the recombinant products. These are products that contain LH activity, either in the form of recombinant LH or ACG. There are many things to choose from. But the main question would be which FSH should I use, and what should be the dose of FSH? I think that's what the questions that we're most asking ourselves on a daily basis. So starting with which FSH to use, there are many comparisons that can be done here, but in the interest of time, I'll just go through the very basic ones. So we have recombinant FSH and we have urinary gonadotrophins. And this is the Van Velde, the Cochrane library meta-analysis, which was back in 2011. It hasn't been updated for quite some time. And overall, you can see that the odds ratio is almost close to 1, and there is no significant difference. And as the patient and the authors themselves in that Cochrane systematic review have pointed out, that the clinical choice of gonadotrophin should depend on availability, convenience, and costs. So essentially, these are the things that should be potentially based on a live birth rate in the first cycle and should be dictating your decision. But let's not forget that there's many times more things than we initially anticipate. And as you saw, this is a 2011 meta-analysis, which means that the studies that have been published there actually precede that by quite a significant amount of time. But now our thoughts have evolved. And now we're also more interested, not just in the fresh embryo transfer outcome, but also in the cumulative live birth rates. And we have already shown that having more eggs, meaning that the cumulative live birth rates would increase. So how does this affect the discussion we're having right now, where there are many FSH isoforms, and depending on the isoforms, these are naturally occurring isoforms, and we need always to be aware that these isoforms, being glycoproteins, they have different glycosylation sites, and there are different compounds that will bind to these sites, and that means that certain isoforms will be more acidic, and being more acidic means that they will have a longer half-life, but they will have a lower biological activity, and others would be more basic, and the basics would be far more potent and would have, however, a shorter biological life. And if you see here, the red essentially is the more basic forms, and you can see that this is day one, that essentially they start from the same, but the initial probably 10 days in the natural menstrual cycle are dominated by more acidic forms. And just the last few days before ovulation, we have the really basic and potent versions. And then it goes down, and again, we have more acidic forms. But if you look here, despite the fact, for example, that on day one, we have almost equal concentration of acidic and basic forms of FSH, you can see that in terms of biopotency, it's night and day. Sorry, let me go back. You can see that the acidic forms are far less active and biopotent than what the basic forms are. And this has, and obviously in a natural cycle, that's what we want to do. We want to start with lower doses, a constant stimulus of a lower potency drug so that we don't end up with 3 or 4 or 5 eggs recruited. But then at the end, we want to make sure we give a good boost so that we have a healthy follicular growth at the end of the follicular phase. However, when we do ovarian stimulation for IVF, that might not be the ideal scenario because we want to induce multifollicular growth. So if we go back at the Mary trial, and that's a trial which we published in 2009, something that many people have not looked. As you do know, the Mary trial showed that essentially the two HMG and recombinant FSH were more or less identical in terms of live birth and ongoing pregnancy rates. But if you look at the follicular growth, you can see that FSH seems to induce a far significantly, a far greater follicular growth compared to HMG. And that translates eventually to almost 2 more oocytes retrieved. And why, you might ask? They have used the same dose. Well, because as I showed earlier, and what you should know is recombinant FSH is by definition more basic than urinary HMG. You need to, if I take you back, you will see that we have this type of more acidic version of FSH produced usually when the estrogen content is low. When the estrogen content starts or concentration starts going up, then we do have far more basic versions. So as you do know, HMG is produced by menopausal women, and menopausal women have very low estrogen levels, and that's why that form of gonadotrophin of an FSH is quite acidic and hence is not as potent. Recombinant FSH, on the contrary, is far more basic, and hence it is significantly more potent. And that means that you'll end up with more oocytes. And that is something that you might need to take into account when you're actually selecting on what gonadotrophin to use. What should be the dose of gonadotrophins? Another very important question. Well, it depends on the type of patients and our goals. Again, obviously, we need to be always very mindful that we need to eliminate OHSS. But then, do we want with one cycle to have one euploid embryo just? I think most of us would not like that. We would like something more. Do we want with one cycle to have one live birth only, which means then we look into the cumulative live birth? Or do we want even something that has been discussed in the States? Can we just with one cycle potentially produce more live births, which might mean our patients don't have to go through another egg collection for a second time? So there are different types of patients, and so we have to individualize and customize our approach. So for the predicted poor responder, the first thing I would like to make sure is that you cannot stimulate oocytes that are not there. So regardless of the dose you give, if the patient has nothing to give you, she will give you nothing. If she has only 2 or 3 antral follicles, most likely that's what you're getting. So there are different strategies for these types of patients, which is to ensure that you recruit available follicles, to maximize the number of oocytes you have available before transfer, and to try and increase the number of recruitable follicles. These are different strategies, but more or less are trying to do one thing, and that is give you a higher cumulative chance of live birth for the poor responders. So what should be the maximum starting dose? Should it be 150, 300, 450? And does increasing the dose midway make any difference? Again, if we look at the evidence, this is a recent Cochrane systematic review from Sarah Lamson, and essentially you can see that based on this very interesting systematic review, there is no apparent benefit in going over 300 units per day. So probably with the exception of having a woman who is severely overweight, in any other case, giving more than 300 units is not meaningful. So I think we need to take that as an important message. But what about adjustments? If I don't start correctly, maybe I can salvage the cycle by adjusting things later on. Well, if we look at the basic pharmacokinetic and pharmacodynamic data of FSH, we'll see that it takes at least another 4 to 5 days for any adjustment to be translated to a clinical outcome. And this is a very interesting study by the early 90s, where essentially in poor responders, they doubled the dose of gonadotropins after an initial poor response. And as you can see, despite the fact that they doubled the dose, they ended up with more or less the same number of oocytes retrieved. And that means that getting the starting dose right is key, and we should always have that in mind. What about adjuvants? I won't spend much time here because I do think that the evidence we have is quite weak. I know many of us might be using these adjuvants, but we should try and make our decisions on the basis of evidence. And currently, the evidence it's very weak. So we were amongst the first back in 2012 to identify that potentially the androgens or androgen modulating agents might be important. We did the meta-analysis. The only thing that we back then saw was that potentially transdermal testosterone could be of some value. Then we did our own RCT. Sadly, we weren't able to actually see no difference in the oocytes retrieved or in the live birth rate. And when we updated the meta-analysis, we could still see an effect. But I would say that we were quite dissuaded by our our randomized data, which was applicable for our patients, and we have stopped using testosterone since then. What about DHEA? It seems to be promising, but again, the studies that have been published are not huge. There's heterogeneity. So I think most of us remain unconvinced. Growth hormone, again, we were amongst the first to say that there might be a benefit there using a systematic review and meta-analysis. Further studies that have been published, the most recent systematic review is by Roger Hart, again have failed to show convincingly that this is something that can help. Having said that, it might indeed be promising, but I would urge most of you to try and do studies rather than use it to your own patients. Are there other strategies? We have published a paper in Human Reproduction where we say that a modified natural cycle might be something that many poor responders can respond better to, and probably based on more or less the same concept of repeated egg collections comes the Shanghai protocol, where you can see that it does actually lead to embryos of similar quality, regardless of if they were actually collected in the follicular phase or in the luteal phase, and it can produce eventually the number of eggs retrieved and the number of embryos available for transfer. What about normal responders? I think I won't spend much time here. In terms of oocytes retrieved, having 200 units versus 100 units produces more oocytes. Having 200 to 250 versus 150 again produces more oocytes. No significant difference in normal responders between 300 units and 225. For the cycle cancellation due to poor or high response, again, we can see that probably we should not be using 100 units, and no significant difference between 200 and 150, although the effect size favors a bit at 225 or 200. And no difference between 225 and 300, but interestingly, the effect size seems to be favoring, again, this time the 300. In terms of live birth rates, there is no difference, but again, these are small studies that most of them were not powered to detect any difference there. In the hyper responders, things are now, and this is the last section of my presentation before I conclude. I think that this is a very important message from this slide. We need to ensure that the patients will not have OHSS. We need to avoid OHSS at all costs. But then by doing so, there are two different pathways we can take. One is we can be too conservative and lead the patients to being canceled due to poor ovarian response. And some of you might say, is that even possible? I will say, yes, it is possible, and I will show you the evidence. And the other thing is we need to make sure we can maximize the number of oocytes we can obtain, obviously in a safe way. Why did I say that you can have cycle cancellation due to poor ovarian response? This is a very, very famous study, the Optimist study, recently published. This is a great, study which has taught us many, many lessons. But a very interesting message from this study that we should not overlook is the fact that in the predicted hyper-responders, when they were treated potentially too conservatively with 100 units, 20% of those patients canceled their OPU due to insufficient growth. And 1 in 3% of patients had actually poor ovarian response. Imagine if you had a patient that you have been counseling about avoiding OHSS and they end up with poor ovarian response. I certainly would not consider that a successful ovarian stimulation. And I think the patient would not appreciate that as well. So how can we maximize the number of eggs and avoid OHSS? By using the 3 musketeers approach, as I like to call it, using a generate antagonist, agonist triggering when things seem to be risky, and obviously freeze-all. So the Cochrane Library, back from 2016, has already declared that generate antagonists are at least as safe and at least as effective and significantly safer than generase agonists. We should not forget that. And again, regarding agonist triggering, we know, again, using the Cochrane Library systematic reviews, agonist triggering significantly reduces OHSS rates, but it's also associated with lower ongoing pregnancy rates in autologous cycles, which means that if we want to keep our patients safe, putting the embryo back fresh probably is not something advisable. So what we can do, we can freeze-all. And do we have evidence that the freeze-all strategy is an effective strategy? Well, this is a recent meta-analysis we published with my team in human reproduction. And as you can see, what essentially we observed is that for women that were high responders, like the responders that we're talking about now, we actually ended up with a higher live birth rate when we compared those poor responders with those higher responders with high responders that had a normal fresh embryo transfer. And obviously that is due to the compromised endometrial receptivity. At the same time, what about normal responders? In normal responders, we could not prove benefit, but certainly there was no trend towards an inferior outcome. So if you do have a good cryopreservation system, freezing all might actually, in terms of live birth rates, be a very, very attractive option. What about triggering and freezing all? What if you combine these? So essentially, you're super boosting the safety and efficacy of your strategy. So combined, agonist triggering combined with a freeze-all policy will increase live birth rates while almost eliminating the risk of OHSS. So to conclude, and I would like to thank everyone for their attention, ovarian stimulation aims to collect multiple good quality oocytes. A poor response to ovarian stimulation can be associated with disappointingly low pregnancy rates. An excessive response, on the other hand, can dramatically increase the risk of severe OHSS, and that's something we need to avoid. A high number of oocytes retrieved does seem to be associated with a high number of good quality embryos. It also seems to be associated with a higher number of cases with elevated serum progesterone, which we know will detrimentally affect the endometrial receptivity, and thus the chances of a pregnancy in the first embryo transfer cycle. So we do need to individualize stimulation strategies in order to optimize our outcomes. So we can perform ovarian stimulation with either urinary-derived gonadotrophins or recombinant ones. There are some concerns regarding the use of urinary gonadotrophins regarding purity, batch-to-batch consistency, and the transmission of disease. Recombinant gonadotrophins, as compared to urinary, are more basic, which translates to higher biological activity. That means that they produce more oocytes, which, as we've shown, can be favorable, especially when it comes in terms of cumulative live birth rates. Out of the many biomarkers we have, AIDS, AMH, and AFC seem to be very good at giving us an idea about whether this patient will be a hyper or a poor responder. And they seem to be doing, like particularly comparing AMH and FSH, they seem to be having similar capacity of predicting those outcomes. What about our stimulation strategies? For poor responders, you cannot stimulate oocytes that are not there. Ensuring proper FSH dosing in the beginning of your cycle is crucial. Doses of more than 300 units should probably be avoided, as I said, with the exception of women that have a very heavy women, more than 100 kilos. Increasing the FSH dose midway is not as efficacious as previously thought, or as many people think it could be. There is no convincing evidence on the value of adjuvants, at least so far, and the evidence that we do have seem to be of low quality, so we need to keep searching. And there are alternative strategies with repeated OPUs might be of value, but we don't have any RCTs to actually see whether they would be clinically useful. For normal responders, we need to try and maximize the number of oocytes without compromising the endometrial receptivity. And doses of 200 to 225 is probably the sweet spot for most normal responders. For the high responders, the antagonist should be the first line treatment for predicted high responders. We should again ensure proper FSH dosing so that we don't end up with a patient canceled due to poor response. And GnRH agonist triggering should always be there, and we should be very keen to use it whenever we have any concerns about that patient ending up with severe OHSS. When we do so, obviously, the right thing to do would be to freeze all embryos and postpone the first embryo transfer for the frozen thawed cycle. And we already know that the freeze-all seems to lead to at least as good, if not better, in high responders pregnancy rates after the first embryo transfer. So for your clinical practice, if you were to take a message, is that for poor responders, using 300 units, for normal responders, probably 200 to 225, for high responders, 150, or sometimes even more, but using GnRH antagonists and always having the agonist triggering tool there handy. And with that final message, I would like to thank everyone for their attention. It's obviously a very interesting way, the webinars, of communicating with the patients, but I do appreciate the fact that you've all joined me today, and I'm looking forward to answering some of the questions you have sent in. Thank you.
Thank you, sir, for enlightening us and more than 600 to 700 IVF specialists, those who have joined this. And there are many questions, but I think with the time constraint, we will be having few questions. There is one question: if a woman has an AMH of 2 nanogram, however, on day 2 of COS, AFC is about 5 in both ovaries, would you start COS in this cycle?
So it depends. It depends on what you have seen. And for example, with an AMH of 2, and we're talking about 2 picomoles or 2 nanograms.
Okay.
Because, for example, if it is nanogram, then no, I would not start. She can do better. But if it's 2 picomoles, 5 oocytes probably is where I would think that's a good cycle. So we always have to combine the knowledge we know. Either if this is an IVF naive patient and she's never had a cycle before, then depending on her AMH, and we assume, of course, that the AMH has been properly measured, and by properly, she shouldn't be on the pill. It should be probably measured in the follicular phase, because you know, that's a more accurate, more standardized determination with a good assay. So if we do expect from her AMH values for her to have a higher AFC count, and it's easy for the patient to defer ovarian stimulation, then I would discuss with her whether she would like to defer. If, however, we have 2 picomoles per liter and she has 5 AFCs, then yes, definitely I would start, because I'm not actually expecting many more eggs from her. I would be actually quite happy, delighted to have 5 to 7 eggs from her with an AMH of 2. Does that answer your question?
Yes, sir. Then there is a question. Can you please repeat about the acidic isoform of FSH and which has less bioactive isoforms?
Yeah. So as we've said, FSH being a glycoprotein, there are different naturally occurring isoforms. There are the tetra or the tri-FSH, and depending on what binds with these glycosylation sites, we'll have either more sialic acids or other types, and that will make it more acidic or less acidic, which means then it will be more basic. So we do know that the more acidic forms are produced naturally from the ovaries when women have a low estrogen feedback. That's how the FSH is produced by the pituitary. And that means that the initial phase, in the early follicular phase, probably from the first 10 days of the cycle, that is the dominant phase, that is the dominant isoform of FSH. It's the acidic one, which means it has a lower biological potency, but there is lower variation because there's a longer half-life. At the end, though, when essentially we have more or less selected the dominant follicle, we see, and when the estrogen now is significantly higher, we see that the acidic forms are no longer the most dominant form of FSH produced by the pituitary, but on the contrary, the basic forms go up, and the basic are far more potent. So as we do know, urinary gonadotropins or menotropins are actually produced from women that are menopausal, where the endogenous estrogen level is very, very low. And that is the reason, and we know because we've also analyzed those isoforms, that the urinary gonadotropins are always more acidic, which means, as I said, that they have a longer half-life, but a significantly lower biological potency. On the contrary, we do know that recombinant FSH is far more basic, which means it gives a stronger stimulus. And that is why, that is one of the reasons that we know that when you stimulate a patient with the same dose of recombinant FSH versus urinary gonadotropin, the recombinant FSH is very likely to give you more oocytes. And the Mary trial, for example, which is a big RCT, showed that that could be 2. It could be more, but for the Mary trial, that was two oocytes more.
Right, sir. For the first questions, there is again, I think it was a little overheard. The question is the AMH is 2 nanogram, and on the day second, the AFC is 5. So,
so for 2 nanogram, the nanogram then, that means that in picomoles is about 14. No, I do think that 5 AFCs with 2 nanograms per ml is not a good response. I would make sure, first of all, that the one who's measuring the AFC is doing it in the proper way. We do know that the AFCs is something that you need, a good probe in order to be able to properly measure it. And you do have to be a bit experienced in order to see what is truly an AFC and what is not. And you have to be very systematic. So if I have done that ultrasound and I see that that AFC seems to be low, I will, in many cases, also look into her basal FSH, because that's also a very sensitive number to what's happening with other things like inhibin B and so on and so on. But if everything pointed to the direction that this is a cycle where it doesn't hold the potential that I think this woman can give me based on her AMH and my previous ultrasounds, then I wouldn't start. And this is something I'm very regularly doing. Particularly for poor responders, I try and select the cycles where we can start. Obviously, this is something you discuss with patients in order to make sure that you get the best outcome possible. But you need to explain these things to the patient And the patient needs to be aware that there is variation from cycle to cycle, and that we're hoping that next time we will have 10 AFCs or 12.
Right, sir. The third question is for agonist trigger. Do you monitor LH level and do you add another dose of agonist or low dose LH after 12 hours?
So, what I do, for me, the important thing is, first of all, not making sure that you're not triggering a hypo patient, or you're not attempting to trigger a hypo patient with a LH. So we do know that one of the important things that you need to take into account when you're making a decision to trigger a patient with a LH, with agonist triggering, is to look at their basal LH levels. If the basal LH levels are particularly low, then that patient might not respond well. And that's something you need to have into mind when you're triggering someone. The second thing is, when I do measure, when I do trigger them with agonists, I do not routinely measure their LH and their progesterone. But when I do have concerns, when, for example, their LH is relatively low, their basal LH, I mean, on day 2 was around 3 point something, and I do have concerns, then I might do that, meaning I might ask them to have a blood test 12 hours, within 8 to 12 hours after the agonist trigger, and I will measure both the LH and the progesterone to see whether there's some, and estrogen, of course, to see whether that movement. If things have not actually gone as I would hope, then adding a second dose of LH might actually is something that I would strongly consider. And I would then repeat again the LH measurement, and just before they're having the egg collection.
Right, sir. There is one question regarding current evidence of use of OCP before antagonist cycle.
Yeah, as you do know, that is that is something very, very close to my heart, because we have published the 2 meta-analyses that actually suggest that there is a detrimental effect, and that's why I recommend to everyone who's using an antagonist cycle not to try and schedule or use the OCP. One thing that we do have some indirect evidence for is that obviously, if you're using like something like a progestin or just estrogen to schedule your cycle, that is something that might be better. But the systematic review and meta-analysis that we've published with George Grisiger back in 2011 clearly shows that there is a detrimental effect in terms of ongoing pregnancy rates in these women, and that is why I've stopped doing that for many, many years. By the way, I know that there are, sorry to interrupt you, Dr. Sinal, I know there are recently some retrospective studies and some other studies that are trying to look at the same thing, but obviously, whenever you have randomized studies, you should stick into the randomized studies rather than retrospective studies where the number of biases that could infiltrate is very, very large.
There's one question. Many times I have seen that in PCOS patient, E2 will be already above 600 on stimulation day 4, but follicle will be small, that is 7 to 8 millimeter size. So in such scenario, what do you add? Antag?
So that is again a very interesting question. I would probably wait for a couple more days. I do think that using a fixed day 6 antagonist protocol in these individuals seems to be working the best. It might, you might observe though a more prolonged ovarian stimulation, but on the contrary, we do have the impression that particularly in hyper-responders, using a fixed day 6 protocol will be advantageous compared to using a strictly flexible protocol. You can do either or because there's no hard evidence. But yeah, I would advise against starting the antagonist too soon. I know that many of us are scared that we might lose the cycle altogether, but in these cases, probably I would go for a fixed day 5 or a fixed day 6 start, or you can bring the patient in the next day and see how things are going, and potentially consider adding LH when that LH seems to be creeping to more than 8 international units per liter.
Right, sir. There's one question. How can you predict ICSI outcome in patient with unexplained infertility with previous ICSI failure?
That is a very interesting question. It's not something I covered in my presentation. Well, actually, you cannot. Whenever you have ICSI failure, you're always trying to figure out why things might have happened. And obviously, you will start from the very basics on how was the embryo looking that day. We always, whenever we have an ICSI failure, we always look back to every single detail, who prepped the sperm, who was the scientist that actually made the injections, how were the eggs looking, were there any issues. You always have to be aware and discuss the potential of a repeated ICSI failure for that patient. But you need to do your absolute best in order to ensure that if there was something there that made or that contributed to this outcome happening, it won't happen again. If you do end up having another ICSI failure, or if your patients are too concerned, then potentially you can discuss other options. If, for example, there was no male infertility factor and you have not tried IVF, I would certainly try IVF. I would say, or you can split and say, I would do 50-50 in order to see whether it's the technical issue or not. And other things that have been proposed is doing either PIXI or potentially high mag IMSI. These are things for which there is no evidence, so I'm not too keen to suggest them as clinical management. You just have to make sure that there's nothing there that could be explaining why you observed this outcome.
In which group of patient would you advocate LH supplementation? And is it okay with HMG or LH?
So again, a very, very interesting question and a topic, very close to my heart. We've done a couple of systematic reviews in the past where essentially we showed with Dr. Lehert and colleagues that adding LH to poor ovarian responders might be of some promise. And that was with just recombinant LH. Unfortunately, the SPART trial that followed, which was a huge RCT in poor responders of Bologna criteria, failed to replicate our findings. So I, at this point in time, remain still a bit, I wouldn't say unconvinced, but I would say I still remain hesitant to recommend adding either LH or HMG, meaning ACG-driven LH activity, to a specific group of population. I do think that there is obviously a group that must be, must have some benefit from it, but I do feel that we haven't yet been able to identify what that group is. One group that might be something we could consider, putting more emphasis on is that group where essentially you stimulate and you see that from a certain point onwards, the estradiol is not rising, the LH stays low, and there is, essentially the follicles seem to be remaining stagnant. So that's a group where I would be tempted to add LH, either in the form of recombinant LH or HMG, it doesn't really matter, in order to boost that estrogen output and hopefully to help those follicles grow more.
Sir, there is one question. Is the incidence of aneuploidy more with more number of eggs in younger age patients?
So it's a very interesting question. No, we do know that the incidence of aneuploidy, it is entirely dependent upon, like in the vast majority of patients, on age. So younger patients, they will have a lower incidence of aneuploidy, and I'm talking about the average patients. The number of eggs actually is not determining the chance of aneuploidy or not. What is determining is how many eggs will be aneuploid, but at the same time, it determines how many eggs will be euploid. So that means that regardless of age, the more eggs you have, the more aneuploid eggs you have, but the more genetically normal eggs you have. So what we're interested in is not the percentage. The percentage is not that useful. What is useful, or what it is important and clinically important, is how many genetically normal embryos that patient will have. And this is what we always need to focus on. not be caught up in the whole discussion about percentages, which can many times be misleading. I would invite everyone who's interested on the topic to go and read our study in 2018 in human reproduction, where we actually discuss why it is elusive and misleading to focus on rates rather than the actual number of genetically normal embryos.
Thank you, sir. And do you recommend any precautions or any guideline during this COVID-19 pandemic for ART treatment planning?
Yeah. So obviously, we're all very concerned with what's happening, and it has put, an extreme strain and pressure on the health sector of so many different countries. I mean, in terms of the evidence, I know you've all seen the evidence currently, or at least, until yesterday that I was monitoring the evidence. It doesn't appear that we have something suggesting that pregnant women are more susceptible to contracting COVID-19. And at the same time, it appears, at least based on the limited evidence that we have so far, that pregnant women will not have a significantly worse outcome if they end up sick with COVID-19 compared to their non-pregnant counterparts. Obviously, this is based on on what we have seen so far. In terms of, we don't have evidence about higher miscarriage rates. There is some evidence for preterm birth, but we don't know whether that was iatrogenic or not. And finally, we don't have any confirmed cases of vertical transmission. I know a number of cases where they try to point to, oh, there could be potentially vertical transmission, but I don't think any of us is still convinced. But again, as I said, the knowledge is still being developed and accumulated as we speak. So we always have to be very cautious. So currently what we're doing here in Australia is, because all elective surgery has stopped, it means that we have been asked to stop doing fresh egg collections and pickups and first embryo transfers. So we're not currently doing that. And we're not doing that for two reasons. The main one is to stop using personal protective equipment that might be used by our anesthetists or other colleagues, especially if the number of cases that need to be intubated becomes more. The other reason is potentially trying to make sure that the patients do not get exposed, and our staff, to COVID-19 by implementing rules of social distancing. So the general approach here in Australia is, obviously there is no contraindication to people conceiving, otherwise we would have to come out and say, use contraception. But personally for my patients, I do tell them that if you can wait, probably it would be a good thing for you to wait a couple of months. Hopefully this whole COVID-19 situation will be behind us. But if there are urgent reasons you need to start treatment, we will start as soon as the government allows us to start treatment. Or if, for example, you need to have a frozen embryo transfer cycle and you cannot wait, then we could still, in theory, do that, but obviously with a great number of caution, a number of precautions, and being very, very cautious.
Thank you, sir, for your enlightening talk and the latest recommendations, latest views, and all our viewers, all our IVF specialists are very happy with your webinar, and we thank you on behalf of INTAS. Thank you, sir.
Thank you. I would like to thank INTAS.
And I also thank my viewers, all my IVF specialists.
I would also like to thank my colleagues that logged in, and I hope they found this educational and interesting. I'm more than happy to discuss anything they might want via email. I would like to, wish everyone in these testing times to stay healthy, to stay safe, and to do the best for yourselves, your families, and your patients.
Thank you.
Thank you.
Good.